Hello, my name is Kevin Sandy, and I'm a second year internal medicine resident at Palmetto General Hospital in Hialeah, Florida. And along with my colleagues, Guillermo Loyola and Oscar Diaz, we'd like to present to you this poster titled Out of Sync, a report of complete heart block. Complete heart block is a potentially life-threatening conduction disorder characterized by the complete absence of electrical impulse transmission from the atria to the ventricles. While commonly associated with advanced age and structural heart disease, complete heart block can also present atypically, particularly in elderly patients. Potential consequences of delayed diagnosis of complete heart block can consist of syncope, heart failure, and even cardiac arrest and death. The case we present to you is of a 79-year-old male who presented atypically with a complete heart block. This 79-year-old male has a past medical history of hypertension and tobacco abuse, who presented with several days' duration of shortness of breath. This was associated with body aches, upper respiratory symptoms, and malaise during the week prior. In the past month, he reports having intermittent episodes of lightheadedness. He was previously hospitalized a few months before with similar episodes of lightheadedness, but refused workup at that time and left against medical advice. At home, the morning before admission, he was noted to have a low oxygen saturation and heart rate. On examination, the patient was alert, oriented, and answering questions appropriately. He was breathing comfortably on supplemental oxygen via nasal cannula. An ECG was performed and was found to have complete heart block with a rate in the 30s. On continuous monitoring, his heart rate continued to drop into the 20s without worsening symptoms. He was then moved to the ICU for placement of a transvenous pacemaker. The patient was not taking any pharmacological agents that could have caused this condition. A transthoracic echocardiogram showed a preserved ejection fraction. Left heart catheterization revealed non-occlusive disease in the coronary arteries. And after this workup, he was taken for permanent pacemaker placement, which led to the resolution of all symptoms. As you can see in the lower left corner of the poster, the top EKG shows the patient on admission with a complete heart block. The subsequent EKG below shows the tracing after the placement of the permanent pacemaker and the resolution of the complete heart block. This case highlights the often atypical presentation of complete heart block in elderly patients. While the classic presentation involves syncope or near syncope due to bradycardia, this patient primarily reported shortness of breath and malaise. Additionally, despite experiencing prior episodes suggestive of complete heart block, he initially declined workup. This stresses the need for thorough clinical evaluation in elderly patients, even when symptoms appear mild or unrelated to cardiac dysfunction. The absence of structural heart disease on echo and non-occlusive coronary arteries on angiography suggests an idiopathic or functional etiology of the complete heart block in this case. The prompt diagnosis and placement of a permanent pacemaker resulted in the complete symptomatic resolution. This emphasizes the critical role of early intervention in managing complete heart block and preventing potential complications such as heart failure or syncope-related injuries. Complete heart block is a complex and catastrophic failure of the heart's conduction system. Physicians must be able to recognize the signs and symptoms promptly to avoid serious complications such as death. Thank you.